Crenshaw. I'm the Executive Director of the African American Policy Forum, and it's my great pleasure to welcome you to the last day of her Dream Deferred, a week on the status of African American women. So first I want to thank everyone who worked with us to make this event possible, especially the folks here at the Kaiser Family Foundation, in particular Lorraine Bullock for allowing us to use this absolutely beautiful space, and for the special pleasure of being able to hold this event at the Barbara Jordan Conference Center. I had to just pause for a moment and share with you that Barbara Jordan was the first person I sent a fangirl letter to when I was in junior high school. I remember seeing this amazing black woman take the stage at the Judiciary Committee. This was back when we had another crazy president that eventually got impeached. And she played no small part in generating the outrage in the country about the fact that this president was undermining, as she would say, the Constitution. I was like, whoever that is, I want to be her when I grow up. And so I sent her a letter, and she sent me back a letter that I have held on to for now over 30 years. So it really is a special pleasure to be here. And I want to invoke her presence in this conversation, in part because, like black women have done so many times in our history and are doing right now, their insistence on not sitting still and being quiet while our basic foundational institutions burn is what has brought us to this moment, and I think it will be what brings us out of this moment if we are true to who we have always been. So with that in mind, I want to open this dialogue that we're going to have today to talk about the particular risk that African American women face, and in this conversation face, with respect to maternal mortality. Now, HDD, as we call it, her Dream Deferred, was begun 4 years ago by the Policy Forum in honor of the fact that the UN has declared this to be the decade of African descendant people. So the particular focus on African descendant women is a product of the focus of our organization. We look at racial justice through an intersectional lens, which specifically means that we look at issues that impact women and other marginalized genders and populations within racial justice discourses and within society at large. How did we come to believe that this was important work that needed to be done? Well, about 4 years ago, the racial justice discourse in the country took an interesting turn with the arrival of male-centered programs and conversations that, on one hand, were very important to raise the ways that racism played out in the lives of our young men, our fathers, our brothers, and our sons. At the same time, it was clear that racism was playing out with respect to women, our daughters, our mothers, our aunts, and that conversation didn't have much traction within our community. So while on one hand, it's abundantly clear that the risk of gun violence, for example, or police brutality, for another example, is a problem disproportionately being borne by black men and boys. It's also true that gun violence, for example, is a problem that's disproportionately borne by black women. So there are ways in which the conversation about racial justice risk overlooked the ways that black women were experiencing many of those same risks. At the same time, there were other issues that were exclusively being faced by black women that we weren't talking about within our community. clearly this topic is one of them, right? So when we talk about disproportionate outcomes, we talk about disproportionate death, and we don't talk about the disproportionate risk of Black women dying in or as a consequence of childbirth, that's a moment of intersectional erasure. That's a moment where we are being forced to take a back seat. That's a moment when we are not moving forward with an anti-racist agenda that includes all of us. So her Dream Deferred was specifically designed to address the kinds of issues that fall out of the conversation when they have to do with people like Black women, when they have to do with issues that we've not traditionally seen as part of the anti-racist agenda. So with the support of Senator Gillibrand from New York and Senator Harris from California, both my states and my senators, they have supported this week with a congressional declaration declaring this week to be the week of the status of Black women, and it has been this week for the last 4 years. So I want to thank them for supporting this issue. So it's been an incredibly moving week so far in DC. We started out Monday at Busboys and Poets with an activist hour in which we talked about many of the issues that we were going to be addressing this week, including this issue. And I see some people from Monday who've stayed with us all week, so thank you for that. On Tuesday, we had 3 virtual events. We had Say Her Name hour on Barbara Arnwine's radio show, in which we talked about African American women who have been killed by the police. We were joined with Rhonda Dormius, who is the mother of Corinne Gaines. She's there in the back, and several of the other mothers. We had a Twitter town hall and a release of a new video from Now This, which features Rhonda. So if you haven't seen it, please see it today. Please tweet it out. Please make sure everyone you know sees this video. Even though the media may have decided that police violence against Black people is no longer an issue, we know otherwise. And we know police violence against Black women is an understood and represented issue. So please look at that video and tweet it out. On Wednesday, we moved to an arts and activism workshop at Google, and we produced a small play of movement, of drumming, of singing, and of artistic performance that we then performed last night at the National Museum of African American History and Culture, all centered on Harriet Tubman and her lasting legacy. So it was a beautiful 2 evenings. And so important, when we got to the end of our Q&A session yesterday, the last question was, what can we and should we do about the crises of Black women's mortality, maternal mortality, particularly here in DC? So we were able to say, amazing that you should ask this question, because we have an amazing panel tomorrow, and we want you all to come out and have a deep conversation about this issue. So let us turn to the issue at hand. Black women are in crises in U.S. With a maternal mortality rate that is the highest of any developed nation. In terms of African American women, our maternal mortality rate is comparable to poorer nations like Iran and Sri Lanka. The World Health Organization found that between 700 to 1,200 women die in the United States each year from pregnancy or childbirth complications. When we look at the rates, the differential rates in the United States, Black women are nearly 250 times more likely, percent more likely to die from childbirth than white women. However, what many people don't realize when they hear that statistic is that Black women's vulnerability to mortality stretches beyond class or education. So another way of putting it, the easy way that people try to dismiss this problem as it's not a race problem, it's just a class problem. Or it's not a class problem per se, it's just a healthcare problem. All of these easy ways of misframing the problem are wrong. And when you have the wrong frame of a problem, either you don't see it or you see it in the wrong way, you are unable to solve the problem and you might even exacerbate the problem. So what we want to do here today is not only make the problem far more visible and bring to the conversation some sister warriors who've been working in this field to lift recognition about this problem, but also to bring all that expertise together to make it available to those who care but may not know much about the problem, to figure out what each of us can do to address this tragedy and create a collective space in which we can share and support each other and our sisters who are facing these risks. So we have a wonderful panelist, a set of panelists. I'm going to get out of the way really soon. Let me introduce who the panelists are. We have Aarin Michele Williams. She is the senior staff attorney at the National Advocates for Pregnant Women. We have Jennie Joseph. She is the CEO and founder of The Birthplace. We have Laurie Bertram Roberts. She is the executive director of the Mississippi Reproductive Freedom Fund. I love the way that sounds. It sounds really, really familiar. And we have Joia Crear-Perry. She's a doctor and president of the National Birth Equity Collaborative. And we have Kira Shepard. She's the director of the Racial Justice Program at Columbia Law School. I ask you to join me in welcoming these wonderful panelists. So we have been talking, we've had a couple conversations with each other, and our goal is to try to figure out how to actually have a conversation with so much of this expertise and this wisdom. And so what we've all agreed to do is to basically limit our comments to a couple minutes each time so that we'll have multiple opportunities to hear from everybody on this panel, and more importantly, to actually have an integrated conversation. That's effectively what we want to have here. And so what we've decided is that we really want to cover this conversation through four different prisms. We want to get a sense of what the actual problem is. Like, what is it? A lot of people have heard things. There's a lot of mythology around the issue. What is the bare truth about maternal mortality confronting Black women? We also want to give space to actually express how we feel about it, right? This isn't just a sterile conversation about some numbers. We're talking about real lives. We're talking about communities. We're talking about a people who are being harmed, tragically so, by the failure to address this problem. And that's going to generate some feelings. People feel a way about this, and we should. So we want to have space for that to be part of this conversation. Thirdly, we want to understand its component parts, right? There's always a moment and a place for analysis. So why does this happen? Why is it allowed to happen? Why is the fact that it's happening being misframed in the way it has been? So what do we need to understand about this problem in order to do the fourth thing we want to talk about? We want to know what we have to do. So that's the decisional part. Given everything we've heard, what we feel, what we understand, what do we need to decide to do about it? So who needs to do what, at what time, when, and how? So all four of these aspects are hopefully going to be part of our conversation. So everyone has given us a few ideas that they want to share. So I'm just going to give people prompts to step into the conversation and share what they would like to put on the table. And I'm going to start with Laurie. We all know that the personal is political, especially when we're talking about maternal mortality and the risks that women face. And you have a very personal point of entry into this work. So could you share with us your point of entry?
Let me make sure. Wait. How do I do this?
And push.
Oh, the little thing that has a like a mouth on it. So bright today. So bright. So yeah, when I was 17, I was experiencing my second pregnancy. I was a young mom. I was a young married mom, actually. I got married at 16, and I was a young mother of twins. I was 12 weeks into my second pregnancy, and I started having pink discharge, and I went to the ER like most people would do, and they said, oh, well, you may be having a miscarriage, you may not, go home, put your feet up, come back if you start bleeding. And I went back when I started bleeding, and they said, oh, well, you are definitely having a miscarriage, the embryo didn't properly grow, but there's a heartbeat, so we're gonna send you home. And what I didn't understand is this is a Catholic hospital, and they are governed by an ethical and religious doctrine. And that meant that they are governed by fetal personhood. And so therefore, the embryo inside me was more important than me. And so they sent me home. And then within hours, I started hemorrhaging. And I was like sitting on my bathroom floor bleeding, and got up, put a diaper on, because that's how heavily I was bleeding. And I just thought, well, maybe this is like post-pregnancy bleeding, and like it'll slow up. And I also I was uninsured, and I didn't want to go back to the hospital, and I didn't want them to send me back home. And so I went next door to my mom's house, and I made a phone call that I needed to make. And then I ended up on the floor, passed out, and on an ambulance ride to the hospital, in shock. Like I remember feeling my body growing cold. My ex-husband talks about how he knew I was dying. He was pretty sure that I was gonna die. And I felt like I was in a tunnel, and I couldn't hear, I could hear everybody, but I couldn't do anything. When I got to the hospital, like my actual family doctor was on staff at the hospital by the time I got there. He was at the ER, because Michigan City, Indiana is not that big. It's only 30,000 people. And he just started yelling, who the fuck sent her home? She could have died. He was this very short, very vocal Nigerian doctor who understood maternal mortality very well, and was very angry. And then I had to have an emergency DNC and a blood transfusion. And I'm lucky that I'm still here, because if I hadn't passed out, I probably would have bled to death, not going back to the hospital. Yeah.
And so these are decisions that are being made every day. Every day. Tell us about what's behind that.
Yeah, so it's really anti-abortion policy, right? It's them thinking that giving you a DNC, even though they're completing a miscarriage, that's an abortion, right? And so the work I do is abortion funding and everything else that goes along with reproductive justice. And I think people a lot of times want to take birth justice and divorce it from abortion, right? But if you don't have autonomy over your body, there's no birth justice. Where is the birth justice? Because if I don't have autonomy over my body, then someone can force me to have a C-section. Someone can force me to do a lot of things that they think is in the best interest of my fetus, right? Or that they think is in the best interest of my pregnancy, whether I think it is or not. And I think that if we don't understand that it's all in totality, it's all a spectrum, and it can't be separated out.
Mm-hmm. So thank you for sharing that story, and thank you for your work that story has inspired. I want to continue along the theme of stories and go to Kara. Hearing Laurie's story, one might think, well, that is a hospital-specific problem or a region-specific problem. But there are other stories like hers, and you've told a story about Tamisha Means. So talk to us about Tamisha's story.
Yeah. So, thank you. So I work at a think tank called Public Rights Private Conscience Project, and we focus on religious exemption laws that examine how religious freedom protections undermine other fundamental rights to liberty and equality. Recently, we came out with a report that examined Catholic hospitals, Catholic healthcare, and their impact on women of color. Catholic hospitals follow, and Laurie was talking about her experience at a Catholic hospital. So they follow a set of directives called ethical and religious directives, a set of guidelines that say that Catholic healthcare providers, they can't perform certain important medical services like contraception, can't give contraception, abortion, sterilization, in vitro fertilization, certain treatments for ectopic pregnancy. So it runs the gamut, right? It's just not abortion. And we recently did a study that showed that in a number of communities across the nation, women of color disproportionately rely on Catholic hospitals compared to with white women. So one of the stories that got us thinking about doing this report is the story of Tamisha Means, as Kim pointed out, because her case is really sad. Just like Laurie's case, she was 18 weeks pregnant when she went to a Catholic hospital, the only hospital in her community, which was a Catholic hospital. She lived in Michigan. She was in a lot of pain. She didn't know what was happening. The doctors examined her, realized that she was most likely, they knew the fetus was no longer viable. They knew that the proper medical standard was to evacuate the uterus. But instead of doing that, or at least telling her, well, we can't do that because we're at a Catholic hospital, or referring her to somewhere else, they just sent her home with a painkiller. Wow. And she had an infection that was on the verge of sepsis, and sepsis is like a life-threatening complication. So she was in a lot of pain, like more pain than someone who's in labor, right? So then she goes home, she's still in like just tremendous pain. She goes back to the hospital. Once again, they send her home. It wasn't until the third time, yes, Tamisha Means there. It wasn't until the third time that she, or up there too. It wasn't until the third time that she went back to the hospital that they began to operate on her because she started to miscarry. Luckily for her, because a lot of women, like, with Laurie, I don't think you realize what happened to you till like years later. So a lot of women don't even realize this happened because they're at a Catholic hospital. They don't even know what's happening. So luckily for her, there was like a woman who was kind of like a public health official / organizer in the hospital, told her to talk to someone from the ACLU, which she did. They took on her case, but she lost at the district and appellate level because the court said that she didn't have a present physical injury. She had all this pain, but it wasn't enough. So those are the issues we're hearing about with women going to these Catholic hospitals. And then because of all the other barriers that women of color face with accessing good health care, is even worse for us. I'm sure we're going to talk about that.
I want to go back to Laurie, because Kira, you just said a lot of women just don't know, what's happened, and Laurie, you said that there's a way in which this kind of trauma is just seen as ordinary. So share your thoughts about it.
Yeah, I mean, I think, especially now that I've been doing this work for a while and I've talked to other women, and I'm a doula, and so I talk a lot about, and I'm a loss doula, and, I carry a lot of women's loss stories and a lot of miscarriage stories, and I've heard over and over again stories that are similar to mine. And when I tell women that that's not the standard of care, like that's not what you should have received, they go, oh, I didn't know. Mm-hmm. I didn't know, and I didn't know, right? And what's really funny is that my ex-husband was like, I knew that they treated you that way because it was a Catholic hospital, right? Like, how the hell did he know? And I didn't, excuse my language, I was about to say something, but I didn't know, right? Like, I didn't know, right? I didn't understand it, but like, he somehow understood it. But I mean, it was also the nexus of being uninsured and also it being a Catholic hospital. I think a lot of times we default to thinking that it's because we're Black and we're poor, and so we expect bad care. Yeah. And that's what I hear over and over from sisters, is that I just assumed it was because I was uninsured and they discounted my pain because they thought I was drug seeking, because we get that a lot. And so like we just internalize that this is the trauma that we have to take, and this is the treatment that we get. And then I also hear that everybody thinks that miscarrying at home is normal, which it can be, like if that's like I mean, like, if that's what you want to do, like, it should be an option that you're given if you're miscarrying naturally and you want to. Like, but that's not the medical standard. Like, let's not act like that's the medical standard. It's freaking not. It's the medical standard in our community because we're being treated badly.
And so you've opened up in identifying all of the ways that the hospital's treatment of you might be understood as class-based, healthcare-based, stereotype-based, right? Denying drugs because of the stereotype of black people, poor people, you know, seeking drugs. So this is an intersectional sort of problem that we're trying to navigate. So I want to go back to Kira. So explain to us what an ERD is, and why are black women disproportionately vulnerable to such things?
So ERD is the ethical religious directives, and they are the guidelines that healthcare providers have to follow. The United States Conference of Catholic Bishops, it's a room full of white bishops, come up with these ERDs, and they basically say that healthcare providers,
You never had a baby.
who never had a baby,
Don't have sex.
basically come up with these guidelines for, you know, what the type of services that healthcare providers have to refuse. So in our study, so basically across the nation, 44 states have Catholic hospitals. We got vital stats data, birth data from 33 of them. Out of the 33, 19 of them we found that women of color disproportionately rely on Catholic health care. And some of those rates are higher in certain states, like certain slides are showing in New Jersey and Maryland, you have a large percent of women of color, Latina and black women who actually go to Catholic hospitals. So just the pure numbers in certain communities are larger. But then on top of that, like our report, we talk about how Catholic healthcare kind of exacerbates and compounds the healthcare disparities and racial disparities that women of color already face. And we're going to be talking a lot more about that on this panel, of course. But studies have shown that, you know, doctors have implicit bias, and because of their implicit bias, women of color actually receive a substandard type of care. ProPublica and NPR recently did, you know, a great investigation on maternal mortality, and they spoke to over 200 African American mothers who repeatedly said that they felt devalued and disrespected when they went to doctors. So this is like impacting women's experiences. It's causing actually more complications for women, pregnancy complications. And then outside of this implicit bias, we know that studies have shown that doctors have direct racial biases as it comes to biological differences. So basically, a lot of doctors, healthcare providers, actually believe that black people can withstand more pain. So because of that, they undertreat us for pain. And they still believe that, like, in 2018, it's crazy. And then every time I think about, like, the Tamisha Means story, the fact that they just sent her home with a painkiller, I think about the fact that they, you know, they undertreat us for pain. She was in excruciating pain, but they probably thought, oh, this woman, she can handle it, you know?
They gave me nothing.
They gave Laurie nothing. Black women have higher unintended pregnancy rates. And with Catholic hospitals, one thing they don't allow is tubal ligations, for you to have your tubes tied. So what a lot of women do, because it's the cheaper and it's the safest time to get your tubes tied, is like right after you give birth, right? But a lot of women actually find out in a Catholic hospital while they're on an operating table that they won't allow that procedure. So the hospital that Tamisha Means was in, was that organizer, public health organizer Fisher was in, she told me stories about seeing young black women coming in there, having a baby, asking to have their tubes tied. The doctor would say, no, we can't do this. Now, sometimes I don't even tell them, don't feel like they even have to bother, give them the respect enough to tell them why. And then after those women would have their babies, months later, she would see the same women coming into the hospitals pregnant, you know? And then like, you know, we could go on and on forever, but like, you know, if you have unintended pregnancy and you don't have proper health care, then there's a higher chance that you might have pregnancy complications, that you might die during delivery. So people should be able to choose when they have a child, you know, this is very important. And then they talked about this in the ProPublica investigation, and I thought it was great because I feel like we all know this. I think that as Black women, like at least a lot of my friends, we always say that racism is killing us, but racism is literally killing us. The ProPublica investigation talked about this study by this woman named Aarin, and it talked about this idea of weathering, which kind of posits that cumulative stress that Black people take on through social and economic adversity, political marginalization, it actually causes us to have like early health deterioration compared to white people. And she found out these stressors are endured by Black women at a higher rate than Black men, and that makes sense because we're dealing with sexism, racism, and sometimes if you're poor, you're dealing with a whole bunch of economic adversity. And in her study, they studied the telomeres, which is like the chromosomal markers of aging of Black women in their 40s and 50s, and saw that they appear to be 7 years older than white women in the same age group. So yeah, and it's based on she calls it economic and social adversity. I mean, that's just like a lot of racism, basically. So yeah, so this is like a serious issue.
So on that note, I'd like to bring Joia in. So at this point, we've heard about the intersection of vulnerability, both in terms of where and how Black women are getting care, what kind of care they're getting, how stereotypes are shaping the care. All of this exacerbating basically our vulnerability. We've heard about some of the data that actually show that all of these risk factors, it's not in our head, it actually is being embodied, and at the same time the conversation about race and our vulnerability is basically saying race where? There's no racism, right? So I know that there's an important part of this conversation that's data-driven, so I want to ask you a little bit about that. And then I want to ask, so what's the data up against, right? What are we struggling to get this data to do that seems difficult to get people to recognize?
So I love that recently there was some data around that there was an astronaut that went out into space, right? And his telomeres changed. I said, maybe we could stop talking about Black folks and racism in our telomeres. So maybe we finally understand that when you traumatize people, it does change their genetics. And so instead of concentrating on if our genes change or if our telomeres get longer, we can just stop being racist, right? Like we can work on actively being anti-racist, to your point earlier. So there's some data, because we usually talk about death and infant mortality, maternal mortality around poverty and class, and we know, especially because of the data coming out of New York City, that despite our income or despite our educational level, that we have higher rates of maternal mortality.
Racism.
Yeah, so when you show that, and race is a social construct, I have to say that everywhere I go. I went to medical school in Louisiana in 1997, and my professor said that there were 3 races: Mongoloid, Caucasoid, Negroid, right? So we still have, to your point, we still have providers, physicians who believe race is genetic. So we have to constantly explain, no, we didn't create this. So because race is a social construct, then unbodying how these policies created these inequities, right? So we know the frame is off. So the frame says that we are just obese, but Black mothers who are normal weight were more likely to die than white mothers who are obese. We know that.
Say that again.
Right? So I can do all my crunching.
Say it louder for the people in the back.
Black mothers who are normal weight have higher rates of mortality than white mothers who are obese. So this is not about us being so fat. And first of all, we were never 4 times more fat anyway, so that was made up anyway. But
thank you.
Black women who live in the richest neighborhoods were more likely to die than white women who lived in the poorest neighborhoods. This was the one that's hard for healthcare providers to really wrap their brains around. Black women who receive prenatal care in the first trimester were still more likely to have a poor outcome than a white woman who had no prenatal care.
Yep.
Okay, so think of all the interventions we come up with. Y'all just need to lose weight, you need to go to school, and you need to go to the doctor. None of those things are going to get us out of it, because what we need, on top of those things, yes, I could do some more crunchies, but what we need is y'all to stop being so racist, right?
Right.
So what we need
Thank
is, right? It's not killing us. And so, but I do think, and I guess I'm at the point where keep getting more data around how racism is killing us. I don't know how much more we need. Like, when are we going to believe it? When is it going to be the pivot from black is a risk factor to racism? So then let's stop it. Let's fix that. How do we get that into the conversation?
So there's a saying that if the facts don't fit the frame, people will reject the facts, right? So it's not primarily a data issue.
No.
It's a frame issue. So what are some of the reasons why the misframing is just so hard to hard to challenge?
I mean, it is what our country is built on, right? Like, it is this belief of the inferiority of black folks and women. So you put those two things together and you get maternal mortality rates that you have. It's built into our every institution. It's built into our how we put our policies together. It's built into, so even, I'm thinking about your data around Catholic hospitals. There are some states where the Medicaid providers are Catholic hospitals. They're the only Medicaid provider. So if you are, so your only option is a place that won't tie your tubes, but yet you complain because they have too many children. How is this even logical? Like, what is logical? So, you know, I think until we have been working really hard on individuals changing their behaviors without challenging systems, without challenging the fact that people actually win, right? They're making money off of our inequities. They make money, they keep power, they keep money. Like, even if you're not making more money as an individual, the feeling of privilege is real, and the feeling of being better than some others is really important. So that's inside of our healthcare system. That's inside of, and it's honestly inside of some black folks too, right? So we could have a black provider who feels the same. Well, at least I went to school, and you little poor person did not. And that is not helping us at all.
So on that note, about some of the ways that the messages about us are internalized. You know, if we historicize black women and our reproductive life, it's always been politicized, right? I mean, our coming here and our reproduction was part of the economy, right? So the idea of us as mothers has always been subject to political, economic, and other determinants. So while we're on that theme, I wanted to broaden our conversation a little bit and bring in a conversation that sometimes doesn't get to be part of this, and that's the criminalization of black mothers. So I want to think about how the criminalization further exacerbates the mortality of mothers as well as infants. What is it that we need to be weaving into this conversation that typically isn't usually part of it?
Everything. Everything. But no, really. You know, I work for National Advocates for Pregnant Women, which advocates, which is a nonprofit legal organization that works to you know, secure the civil and human rights of pregnant women, which are often black women, low-income women, and women who are drug using and drug dependent. And so what that means is we're defending women, right? And we're helping people defend women who are, like Laurie mentioned and brought into the conversation, that's not often brought into this conversation, who have abortions, right? Women who, for a variety of reasons, have to have their children at home. And if their home birth results in a miscarriage, or if it results in a stillbirth, are prosecuted, are arrested, are detained, or deprived of a lot of their rights. And a lot of us don't know that this is going on. Honestly, I really didn't fully realize and recognize it myself, right? And so, and that's related to, and we often defend women who are drug using and drug dependent. And that's where this conversation about criminalization is brought in. Because so often people are thinking, like, why is the lawyer who represents women who want to have or who have abortions, or represents the women who create these crack babies at a table or in a room with people who are advocating to save babies or to save the deserving mamas? And we have to recognize that it is all of that. It is a reproductive justice approach. And that requires us to have conversations about all of it. And so that means we have to think about the war on drugs and the myth that we have all bought into about that crack baby, right? And the women who use drugs, and what it looks like, not only just shackling, right? Because I know that's I'm often asked about the shackling, but like what it means when we are saying that, going against the science that says that the crack baby era, all of that is a myth. And when we're talking about criminalization, we're so often thinking about the man or the black woman or the black child, which we should be, but we're not bringing into the conversation that black pregnant woman that leads to those images or these images right up there, and how we buy into that and we support or are silent when the women whose children those are decades later on magazine covers. And what we are willing to allow to happen to those women when we've bought into these systems that want to continue to make money off of our children and are continuing to do so. And so what that looks like in AAPW world is like Jennifer Johnson, who was a black Florida mother, who was the first person in the United States, first woman to be charged and convicted of distribution of cocaine to her baby through the umbilical cord. And she was sentenced to 14 years on probation. Right, so maybe not 14 years in prison, but we know what probation means too. 14 years on probation, so that's money, right? And that's constant harassment, surveillance, money, all of that. Or it looks like Kenlecia Jones, a black mother from Georgia, who took misoprostol, a safe and legal medication that can bring on early labor so that she could go back to work a little sooner to take care of her children, right? And so when she went into the hospital to seek care, and unfortunately the baby did not survive, and she asked the hospital to save her baby. And that when that didn't happen, she was charged with murder. Right? And even beyond just that, right? So then she's taken from the hospital into the police precinct, mourning, emotionally and physically in pain, and bleeding, and she's not even given basic human dignity. She is not given sanitary napkins. She is not provided new clothes. She still has to sit there in bloody clothes. Or it looks like Latice Fisher, who just yesterday, thankfully, is a Mississippi woman, thankful to NAPW, thankful to Laurie and the Mississippi Reproductive Freedom Project and Color of Change, got out of jail yesterday. Yes, she's out. But she sat in for 57 days, away from her husband, away from her children, because the DA, a black man who ran on a progressive platform and is young, right? He decided that it was appropriate to charge her, and she's out of jail, but she's still charged with second-degree murder because she Googled misoprostol on her phone a few weeks before she had a home delivery, and that to him is enough. Right? And that's all you need. Right? Or it looks like the women in Alabama, hundreds and hundreds and hundreds of women in Alabama who are charged with chemical endangerment to a child. All of those laws, murder, distribution of drugs, chemical endangerment to a child, are not intended legally, are not intended to go apply to pregnant women, but they're being applied. They're being expanded to apply to those women. And so in Alabama, what that means is that what the law was intended to do was to prosecute people who brought their children, or brought children at all, into meth labs. But what prosecutors have been doing is expanding it to apply to women who are bringing their children into dangerous environments, which are their wombs. And this is not a new narrative.
No.
And I mean that picture with the young lady, I'm sure a lot of us have seen this, the beautiful girl in the pink dress, is from 2011. But the picture on the other side, right, that's from the 1700s, and we are still perpetuating these same ideas. But we have to understand that we cannot get the moral and political will to gain the resources to address these health issues that we're discussing, if we continue to legitimize not only the criminal system, but the punitive child welfare system, because that's a whole not even another conversation, but this has to be also be a part. And so when we're talking about ending racism, we're talking about ending mass criminalization. And so we cannot separate that just because we don't like that a woman is using drugs and being pregnant. We have to change that narrative. We have to change it from within, and stop ignoring people.
So I can imagine that inside of our own community, the link that you are articulating is one that many of our more respectability-oriented folks would really have an issue with.
Oh yeah.
Right?
Yeah.
So what would you say to those who say these issues have to remain separate? Because one of the issues that our mothers are facing is all of the stereotypes that we talked about earlier, right? So if we have all these stereotypes, they're not good mothers, they're just engaging in drug-seeking behavior, they put their children in danger, and our fight is against that, right? What kind of conversation do we have to have within our community, even within the group of us who are concerned about this issue, to make it clear that it's not a viable option to try to fully separate these conversations?
I mean, in my head, it's really simple that if we cannot save Black babies, we cannot save Black children, we cannot save Black communities if we do not support Black women. Yeah. We're the cornerstone of the Black communities, even for these respectability politics, we're the cornerstone. So if you are trying to save that child up there, how are you going to do that if you are locking up the parents? Yeah. It makes no sense. Or, let's talk about social determinants. And I know that's what we are saying, but let's put a name to a thing. Social determinants are like a societal womb, if you will. Like, that is about the distribution of wealth, the distribution of power, the distribution of resources. And those social determinants affect at least 50% of health outcomes. That's what does. Right? And so this idea that an individual's one decision for 10 months, if you even carry to 10 months, is actually what's impacting someone is not true. It's about the 34 years or so before, or 20 years or so before I actually have a child, if I choose to do so, or if I have one at all. It's more about those impacts, those social determinants, and not the individual things. So women, Black women, we're being judged more on what we're putting into our bodies than we are on what we're putting into communities or into our families. And that just makes no sense if you really want to talk about the stresses and the racism. Like, we have to include the unsavory things too. And that's what I tell them.
Can I just piggyback? I will never understand how a positive drug test can trump parental behavior. Right? So you can have, I think people misunderstand that you can be a functional drug user, right? So you can have someone who absolutely tests positive for drug using and who is a good parent.
Completely.
Like, I think that people think that those things don't go together, but they absolutely do. So we have families that are ripped apart who are not neglecting their children. They're not out here like they are not stereotypes from 90s movies. Like, this is not all New Jack City and Boys in the Hood. Like, can we please let that go? Right. And also, we cannot heal our community and build our community by saying we'll support only these mothers. Yeah. We're only supporting Claire Huxtable.
Yes. Jesus.
We ain't supporting no other mamas. Right? Like, we ain't supporting no other mamas, just these mamas. Like, you either support mamas or you don't.
Yes. And when we weave that in, we ignore them. I don't want to step over it.
Joia, and then I'm going to come to Jennie to help us think our way out of this.
Okay. I just wanted to add that we already have evidence that frame doesn't work, right?
Right.
So, like, from Du Bois, from the beginning of time, we've tried to say we'll assuage the thinking that we're not fully amazing and talented 10th, and if you just only see how amazing we are and smart and we speak 10 languages, you will value us, and that just doesn't work. So there are just as many people who are on drugs who are white as black. There are just as many, we don't have a corner market on having drug addiction babies. I mean, heroin addiction right now is showing us that. And a lot of my peers cannot see white women as addicted to drugs. So the reason that they have these babies that are in the NICU is because they don't even want to challenge white women that they're on drugs. And that is a problem. So until we can see that all of us are fully human, no matter what our race is, and embrace all of that we bring to the table, we're going to keep having these problems.
So on that note, I want to sort of broaden the framework a little bit and just get a sense of alternative realities, right? So Jennie, you are familiar with, you've done this work internationally, specifically in the UK, which has a much better record with respect to Black maternal mortality. So what is it that characterizes a system that gets it right? What is it that's right about these places where the rates are lower, and how is it that can help us navigate what appears to be intractable problems, right? The intersection of racism, class, all of these things make people run away thinking, well, nothing can be done. That's the fatalism, that attends to issues having to do with us. But you think otherwise from experience. So tell us about the experience in the UK. Tell us about your own experience where you're doing this work.
Yes, absolutely. The United Kingdom has social medicine. Everybody has access to healthcare. Healthcare is a human right. I think that's one good place to start.
Right.
I got here in 1989, I got off a plane and had no clue what I was coming to. I came to Disney, and I'm still in Orlando, and no, it's not Disney anymore. So what I do know is that when you look at this problem from a perspective of access, that's the number one thing that I really try to bring into the practice that I do. I'm a midwife, I have a birth center practice, but I also have a clinic where I do outreach. I call it the Easy Access Clinic, because that's the problem. The problem is lack of access. And it's not just access to getting in the door and having prenatal care. It's access to the quality of the care. It's access to respect. It's access to emotional support. It's access to acknowledgement. It's access to seeing you. It's access to where are you, what you need. That is the access piece. And when you have that, you have the opposite outcome than we're talking about today. I think it's also important to think about that this is maternal mortality that we're discussing, but morbidity is rife. So you didn't die. Here's the story. You did not die, so you're still in jeopardy, but you're not counted in the same way. So we have the numbers on mortality, and only because we started looking recently, not because this is a crisis. This is not a new thing. This is historical. So we have to consider that to mitigate this, and what is seemingly intractable, you can actually address it very readily. Find a way for women to have an access point. Keep that point being open to everybody that needs it. And then once you have her on board and she's in the having the ability to talk about what's going on for her, this is not just medical care that's needed, it's wraparound care. It's all the aspects of motherhood, womanhood, family. And when you bring that into the deliverance of care, you get a better outcome. As a midwife, that comes as second nature to me. But it's not about being a midwife. It's about a midwifery model, which is a patient-centered, a woman-centered, a family-centered model of care. It's about looking at your bias and understanding the impact of your bias. Racism is indeed killing our women, killing our mothers, killing our fathers, killing our families. Without looking at that as part of this deeply entrenched, institutionalized system that says this way of being is okay. And not only is it okay, but you can't get in. We won't let you in. This is where we're going in these circles where we're not getting to solve the problem. So the things that work for me, the things that allow us as a small midwife-led clinic and practice to come up every year with no premature babies or just a couple that are thriving anyway, no low birth weight babies, women who don't have preeclampsia, women who don't have gestational diabetes, women who aren't wretched, but come out the other end with a natural, normal birth in a hospital environment, breastfeeding their children and thriving. The thing that gets us there is allowing access first and foremost, connecting very quickly with the woman and connecting her, then helping her navigate the thinking system. We know, so we have to share. And once a woman understands her way around, her family understands how to support her to have her way around, she's empowered, they're empowered. The statistics disappear. Full-term healthy babies, full-term happy mothers and families, breastfeeding women, women who can stand for themselves, women who discover their power and can come back out the other end and be able to survive. This is what we're looking for. How do we educate, support, and empower, and use the skills that we have, the tools that we have? These are the very things that don't cost any money. It's time for change, and so we found that this is working, and I really wanted to talk more about how can we individually find solutions to this horrible and egregious situation that we're in this country.
So, Jennie, you mentioned the systems, right? And I want to talk a little bit about not just the women navigating the system, but providers navigating the system. So what's the flip side of that that is an important part of the solution here?
One of the things I found when I first got here was it was a lot of push towards educating women about, oh, you need to know how your cervix dilates, because otherwise, you know, you're just going to be lost. And I realized, you know who needs to be educated? The providers. We don't even know our own systems, nor do we care to. It's much easier to just keep doing the same thing and not rock the boat. And I understand why. You know, when you do all the work and you pay all your money and your education and you get to the other end, even though you started with a great sense of heart and hope for providing and supporting your fellow human being, on the other side of that, you're burned out, wretched, exhausted, poor, miserable, scared. And you have to then join in with what's so. So I really felt that the work needed to be in terms of educating providers inside of these systems to figure out how they too can negotiate and keep themselves whole. And it's a job, because the weathering that we are trying to fight on behalf of the women and their families, we are experiencing ourselves. The superwoman, the Wonder Woman, the, oh, I can do everything, I can be everywhere, I can live this life where I'm making a difference. It's not so easy to achieve, because we're also victims of the same system.
Say that.
So the same framework that is keeping these women down and having our women suffer and die is killing us. So then I'm looking at, well, how can we educate and support each other as providers? How can we infiltrate and fly under the radar? How can we bring the same 4 tenets that I apply to the women, which are access, connections, knowledge, and empowerment? How can we bring those same 4 pieces to each other? How can we share with those of our colleagues who have power why they need to help us to now redress the balance? We need to be talking to the risk managers. We need to be talking to the hospital boards. We need to be talking to the owners. What I'm looking at now is this whole work is on a double-sided prong. The clients, the patients, and the providers in tandem, working together from the inside out. Because we can't go out on a limb and put ourselves in jeopardy and lose our positions and lose our tenure and lose our jobs to do this work. We have families, just like everybody else.
Thank you.
So we have a whole lot of work to do. I really feel like you know, the movement needs to become, first, let's tell the truth.
Yes.
We can go from there. That's maternal justice in my world. That's what I think I'm doing.
So on the theme of access and telling the truth, I want to come into this zip code. If there's a ground zero, maybe there are a lot of places that can compete, but DC would be on the list. Right? So I want to talk about the actual local conditions around which this issue is being manifest. So Joia, help us understand what the face of the problem is here in DC, and then I want to know about what's happening in your neck of the woods.
I see some of my fellow DC folks in here, Anthony and here we go. So, you know, recently there were some closures of hospitals, specifically Ward 7 and 8. I know y'all getting some media attention. We have a great short movie about it that Ebony's in. And talking about kind of the why, right? What does it look like that you can close down hospitals for a whole population of people that you know are already transportation challenged? That you recognize this is not just transportation to a doctor's visit, but transportation to jobs, transportation to child care. Like it is Ward 7 and 8 have historically had issues with transportation, and yet now we're closing down hospital systems. And really, when do we start challenging the hospitals that are open about what their responsibilities are in that space? Because what we tend to do in this narrative is say, oh, the hospitals didn't have very much volume, or oh, they weren't the ones that had, you know, as much, their outcomes weren't as good as the others. We demonize kind of the hospitals that had lower resource without looking at the folks who have high resource and say, what is your obligation to this community? What are you doing for people who you know have lack of access? There are some, we recently got a bill passed to start a maternal mortality review committee here in the city. And why that's really important is most maternal mortality reviews are state-led. And, you know, we're working on statehood. I'm a new DC Washingtonian. But until that happens, it's really important that DC look at that. The last reports that we have through CDC, there were 67 deaths, and 63 of them were Black women. So if you think about what that means, do we know that DC is become not Chocolate City anymore? So the inequities that you see in New York City and DC versus kind of the 3 to 4 things that you see kind of in Texas is not because those places, it's because that the white folks are doing so well. So in New York City, the numbers, the gap, the 12 to 1 is because if you're white in New York City, you do really, really well. If you're white in Texas, you're struggling. If you're white in DC, you're doing really, really well. And so what does the access to healthcare get you in DC that it does not get you in other places?
And George, fill us in on what's happening in Mississippi. And I want to say we're going to be moving to Q&A, so if you have a question, prepare it, and we'll be around with the mic in a moment.
Yeah, so I'm just gonna warn y'all, I curse a lot. So I'm just gonna say to y'all, Mississippi is a clusterfuck of all the things that make for bad Black maternal mortality rates. We don't have Medicaid expansion. We have lack of providers. We have whole counties in some places that have no OBGYNs that provide for Medicaid patients. We have lack of public transportation infrastructure, even in our capital city. There's just huge swaths of reasons. Oh yeah, and we have a really big history of racism and oppression, in case no one's ever heard of Mississippi. So I made sure to bring up this this map because all of those really, really red counties are the ones with the highest infant mortality rates. But those really red counties, many of those are where we get the highest call volume for abortion assistance, especially those ones that are in the Delta. Matter of fact, our 4 highest call volume areas are around Jackson, the Mississippi Delta, the Pine Belt area, which is on their way to like Meridian, which is kind of away from Jackson going towards Alabama, and then the Mississippi coast, the Gulf Coast, which are all, if you look, red counties, red counties, red counties, lighter red counties, pink counties. So I can't say there's a correlation, but I mean, like, am I surprised? Not really, because one of the feedback things we get from a lot of our callers is fear of having another birth if they're having really bad traumatic births. Like one of the things that I want to address in our community is unaddressed birth trauma. I hear a lot of talk about it within the white community and the white birth community, but there's not a lot of talk about it within the Black birth community. And frankly, let me also say there's not a big Black birth community in Mississippi, despite us having one of the highest per capita Black populations in the country. We have 1 Black home birth midwife in the whole state, and we have, and there's only 6 white ones. And we have, I can count the Black doulas on my hands. that are practicing in the state, and I practice only to part-time. Our C-section rates are some of the highest in the country. We have some hospitals that have an 86.3% C-section rate. The C-section rate in Jackson, Mississippi is 49.6%. But overall for Mississippi is 38.2%. The WHO recommendation is 10 to 15%. In some counties, the maternal mortality rate is as high as 595 deaths per 100,000. That's for Chickasaw County, Mississippi, for Black women. Like that is comparable to Rwanda. So like when I say it's extreme, it's extreme. And the reason I put this chart up is, so infant mortality rates, Mississippi likes to make a big deal about how they went down. So they went down, but it's still 70% higher for Black women than white women. That's I pulled these out of the Mississippi State's report. It ain't like I made some graphs. Like I'm not making no graphs, okay? But lastly, before I give up the mic, I want to say there is something that benefits the state and those in power by making sure the narrative stays on. Because in this report, they kept saying, well, a lot of these women are obese, they smoke, they sleep with their babies in unsafe situations, like basically they ain't got no cribs, they smoking in the house, they're irresponsible, you know how them poor Black people live. But there's something, and they're obese and hypertensive and they have diabetes, right? And I put that slide up there not to say that this is what we need to address, but to say that this is the narrative they push. Right, I'm with you, Joy, right? But because there's a benefit to that, right? And it goes right along with the narrative that they have for abortion, right? Is that Black women have abortions because we're irresponsible mothers who don't want to have babies, because we're horrible people who don't care about babies because we hate babies, right? So it's like it's the same narrative, because we don't care about ourselves and we don't care about ourselves enough to take care of ourselves to have babies, right? That we're dangerous to babies. And like that benefits them in that they stand on our backs to push their wedge issues so they can gain and keep power. Right? Like I always want to remind people of that. Like these narratives benefit them to keep them in power.
So truth there. Okay, we're going to take several questions. So I'm proposing to take maybe 3 questions, and you all choose which ones you want to address. We have about 15-20 minutes for Q&A.
Hi guys, thank you so much for this panel discussion. My first statement is to Jennie. Jennie, I read your article on New York Times. I was so impressed. Thank you. Have you thought of creating a curriculum so that you could work with obstetricians in their training so that they can be well trained? And then one question and one comment for Laurie, thank you. Laurie, I'm so sorry you had that experience. You made a comment that I wanted to educate people. First of all, I'm a OBGYN and I'm a fellow. There are different ways to manage miscarriage. I don't want anyone, when I send you home, because we're planning to do expected management, you say that's against protocol. It is part of ECOG management, and it's in the practice bulletin. I looked it up just in case I was wrong. So expected management is part of the process, but I agree with you, those physicians were not good customer service providers. They should have educated you better. Thank you.
That's why, let me just back up.
Okay.
That's why, you can wait. We're going to get a couple more. Couple more.
Oh, sorry.
Couple more. That's okay, that's okay.
That's why I said they should get
Thank you all so much for really just fighting on behalf of us. Like you, Laurie, I was a young mother of twins. I was 22, pregnant here in the district. And I was told to have amniocentesis done, talk to a genetic counselor. I was given the option of selective reduction even before any of these tests were done. And my question is, my twins are beautiful. They're 11 years old now. Oh, there goes Aarin down the shirt. They're 11 years old now, but they are healthy, happy, intelligent. I mean, absolutely nothing wrong, right? My question is, how do we educate our young women about the questions that they should be asking when they are pregnant and they are going to see their healthcare providers who may not actually have their best interest at heart? I have boy-girl twins. I'm talking to my son about how to interact. how to interact with authority and with the criminal justice system. Same for my daughter as well. I think that this is an important conversation for them. I also serve on the Board of Education in my hometown, and I would really love to know, like, how can we incorporate this into the curriculum for sex education, health education, and do you know of anyone who's doing this work right now for our kids?
One last question.
Good afternoon, and I echo, of course, the thanks that everyone has expressed earlier. I wanted to get, and this is for you, Ms. Kyra Shepard. I hope I pronounced that correctly. I wanted to get a bit more texture or context regarding some of your details and stats you've told us about Catholic hospitals in particular, because as you talk to us, of course what you're saying sounds deplorable, but I'm sitting here wondering, is it more a question of access and lack of choice? Are these the only hospitals there that these women can go to? Because it sort of seems right now the narrative is more like, see how bad Catholic hospitals are treating us, as opposed to there's nothing else that these women can go to. And I guess that does impact me a bit as a Black Catholic. So I do want to know a bit more about that and would love to hear your thoughts.
So,
Okay.
first I'd say I'm sorry that I was unclear. I didn't make that as clear as I should have, because at one point I said that they should have offered options.
Correct.
Right?
Correct.
And like, because I understand that, because I had another miscarriage where I was sent home and it was successfully managed at home. So I totally do understand that. So I want to validate that. Yeah. Secondly, as a doula, I completely understand what you're saying for the second question. And my organization incorporates kind of like what if you get pregnant work into our outreach work that we do, including with teens, so like mostly in small groups. I feel like good family planning education should include like education on like what you should be asking when you're pregnant, but also I feel like the expansion of having more doulas trained, and I know people don't always like to hear this, but I'm not saying that every person has to go into business as a doula. I'm saying you can be trained as a doula, and you can be trained as a doula, and you can be trained as a doula, and even if you only support your friends, right, and you and each of you support 5 of your friends, it is a revolutionary act that you all have that information, and you are trained and knowledgeable in birth, so that we now have a trained and knowledgeable community of people supporting each other. And so like that's what I'm saying. And as far as, I'm sorry, the Catholic, I know it was Kira's question, but I don't mean to just call you the Catholic. I'm so sorry. But I will say I believe it's a problem of both, right? So it's access and it's a problem of the policies being bad. Right? So like if you're Catholic and you already know that those policies exist, then you're going in with full knowledge. Those of us who don't know, don't know.
Yeah, and I'll just follow up with Laurie. I mean, I think with some of the data we found that the Catholic hospitals were the sole community providers, so they were the only Catholic hospital in the area. With a lot of hospitals, like with the situation with Tamisha Means, a lot of Catholic hospitals don't have names that you just could tell are just like they're Catholic hospitals. And a lot of times it happens with mergers. So the names are just totally non-Catholic. So a lot of people don't even know they go into the Catholic hospital. And then research actually shows that like women who actually go into Catholic hospitals don't know they follow these directives, and they don't even know how broad these directives are. So you might know that, okay, I might not be able to have an abortion in this hospital. They don't know they can't have like the tube types at these hospitals. So there's like lack of knowledge. And in New Jersey, one of the places where we're going to work to try to push forth like proactive legislation, I mean, Catholic hospitals are the only hospitals that are actually in those communities. A lot of hospitals don't choose to be in those communities. Only Catholic hospitals choose to be in those communities. But that doesn't make it okay because they limit the services to those women, and those women deserve quality services like everyone else.
And I wanted to see who wanted to respond to the question. I call it the talk, question. So there's the talk that we now know, we have to have with our children about police. And about racism in the school system, but are we having the talk around some of the risks that we as Black women are facing around mothers? And if not, what does have to be part of that talk?
Yeah.
Can I?
Go ahead. Yeah. I'd like to address the talk, but also answer some of your questions. This is important here, as far as if we recognize it, if we can start with ourselves, we've got a place to stand. So just asking yourself, how are you negotiating your GYN exam? Let's face it. How long do you sit in that waiting room? How quickly are your legs in the air? And who's talking to you while they're screwed up right between them? Let's start there.
Yeah.
Because if you figure out how you want to be, you can pass on to your daughter, to your son, how they might also want to be. You have to be the model because there's nothing else out there. And then the other side is if we get our providers on board with, let's try something else. So when your question, do I have a curriculum? Yes, I do. Do the OB/GYNs want to hit? No, of course not. But that's okay.
Try it.
Oh, yeah, well, there's one. All right. But the point is, I'm coming from the ground up because coming top down is beyond what I've got any energy left for. So ground up, I'm looking at what's our pipeline? Okay, who can we reach? So yes, doulas, childbirth educators. I have a lot of peer paraprofessional courses that I teach and train. I created certification. I just made some stuff up because I'm like, whatever. Yeah. Stuff that we do gets the women and the men that are interested able to be active in their communities right away. No, it's not a profession. No, they're not going to make any money. They're actually doing a service because they care enough, they want to learn. Also, community health workers, they're already out there. There's in codes for community health workers. You can bill, right? So money can be made. So community health workers, we're training them in the perinatal side of community health work. They are out there, they're on the ground, and these are our future nurses, future midwives, future physicians. This is a long-term work we're going to be doing. This is generational work we're going to have to do. So we can start community-based work sooner than we can get any large institution to acknowledge that they need anything other than a quick cultural competency course and we're all done.
Yeah. So along with having my own organization, I'm on the steering committee of the Black Mamas Matter Alliance. And I think Elizabeth Dawes-Gay, our chair, is over there. And so we have really been working on the talk, or the conversation. One of our tenets is culture shift. And that means going around and doing screenings of the documentary we're in, and also having conversations with communities on Capitol Hill and with others around what does it mean for us to have holistic health care, and what does it mean for Black women to thrive in childbirth. We have Black Maternal Health Week coming up, April 11th through the 17th. So I hope all of you will look up that and participate in Black Maternal Health Week. And it's really just important that we start having these conversations. I have a 25-year-old daughter, and she's seen me do the screening a few times. And she's like, so you're paying for a surrogate? I'm never getting pregnant. And, but so I recognize that the challenge in us talking about our risk is also scaring people. And so I am really conscious of that as a mother who does want my daughter to live, but also wants, at some point, not anytime soon, if y'all know her, not anytime soon, wants her to have a child. And so how do we have these conversations in an empowering way? And how do we talk about changing systems so that we can thrive and we can live? It's important as well.
To piggyback on that, my daughters have made, I have 6 daughters, and my daughters have made their one sister commit to being a midwife so that like they can all give birth with their sisters being their doula and one of them being the midwife. Anyways, I digress, but I almost forgot what I was going to say. I do, shoot, damn it.
Come back.
It'll come back to me. Fudge.
Let me get 3 more questions, and maybe
I hate that.
questions will prompt it. Believe me, it happens to me.
I have fibro. That's my exist.
Okay. So,
good afternoon, everyone. Hi, Kim. Thank you for doing this. My name is Darren Baldwin. I do disability policy, so I want to infuse that in here and talk about women of color with disabilities because they are always left out. They are never in that data. We cannot get disaggregated. The education, just so you know, if you have a child with a disability who has an IEP, which is an education plan, individual education plan, they're not allowed to teach them about sex education, right? That's in the IDEA, which is the Individuals with Disability Education Act. So we need to address this, and we need to make sure we include people with disabilities. The durable medical equipment is not accessible to these women.
Thank you.
Little people, women, women who are in wheelchairs and quads. So I just want to bring that forward. And then I also wanted to say, I heard Capitol Hill mentioned once here, but I'm on the Hill all the time, and you know me, and it is not talked about there. So I'm offering my services to you outside of my professional work, but I'm on the Hill all the time, and this needs to be discussed, and the people who are discussing it are not people who look like us.
And I'll add to that for the question. So what is the current legislation? Because I understand that there's some conversation going on and some movement. So I'm sure people would like to hear about that. Two more.
Thank you very much. So I just first want to say thank you everyone for coming out. And I did just want to know if you guys, we all have supercomputers in our hands or pockets, can also look this up. Just to add this to the conversation, you know, in the UN Charter around genocide, it's very clear that two of the definitions, actually three, one involving forcibly removing children from the home, which we know that all of this narrative you guys are speaking about is used for that justification. That causing, you know, deliberately causing or neglecting to take care of a community or neighborhood such that the people are essentially able to take care for themselves is a way, and then obviously trying to prevent or limit births. And a lot of these things are being done by the government, by the media, by the government, by this whole campaign to present this image, along with then the denial of access to health care. And so my question, as someone who lives in DC, who lives east of the river, Ward 7, trying to have some babies soon, just got this, you know what I'm saying, working on it, so I'm trying to have some babies, and I have nowhere but, and so I mean, my plan now is to hop on an Uber and have it take me all the way to Northwest, but for everybody else who isn't going to do that, because I will get that good health care. What can we do, or what do you think that we can do, those of us who are politically minded, which is everyone in this room, who live in DC or in this area, which I'm guessing is everyone in this room, what can we do? Is there a way that an organization, a nonprofit, a for-profit that we can fund, that we can organize for, that will build us a birth, even just a birthing center, post-prenatal care, you know, postpartum care center, that we can just fund at this point. I think that that's what we need to do. We have a lot of homeowners, Black and brown homeowners who live there, who work 2 jobs, make good enough money that can afford to fund this. And people like ourselves in this room who probably do nonprofit work, organizing, politically minded, who can organize this. Who do we call? How do we get one built here? Because I might need one in about 13, 14 months.
One last question. Let's get this one last one.
Want to get one up here? There's one right here as well. There's like 3 people still.
I'm sorry. I'm like fumbling and I'm about to leave to go catch a baby. I'm here. Yeah. I've created a service, predominantly women of color. We have a birth center. We also do hospital birth. We're here. Yes. So we predominantly serve, I'm at Family Health and Birth Center Community of Hope. We predominantly serve Ward 5, 7, and 8. But we are a predominantly midwife service of color. Yeah. And Community of Hope has allowed me to create a lot of dynamic programs. And I've been there for 3 years, and yeah, come on.
So how do people reach you?
Come on. So we are in Northeast Heckman Jamal. Look at those DC people know what I'm talking about. Yes. Safeway. 801 17th Street. Northeast. Tracy, my love, has some cards in case somebody is interested. We'd love to see you.
Community of Hope. If we can take 2 more really fast, because we only have now 8 more minutes left. So,
okay. Very quickly, I'm just curious, there was a little bit of talk about GYN care before a woman is actually pregnant. As a woman who wants to give birth one day, I kind of noticed a difference in care, and I'm wondering, does that play into this at all? Like, what happens to women, particularly care around, you know, fibroids, endometriosis, all of the other challenges? I'll very quickly. I work for an organization called the White Dress Project, and we did a health fair at the NBC4 Health Expo. every woman, a white woman who came up to our table said, oh, I got that taken care of, I'm good to go. Every black woman was offered a hysterectomy, and some had a hysterectomy, and their right to give birth was basically taken away from them. And so I'm just wondering if that plays into this as well, what's happening to women before they even get pregnant.
Yes. So I think that took up our last question. So can we first go to Aarin, and then you want to say something, and all of you have suggestions, ways of moving forward. So if you can integrate any responses to your question, to the questions that came to you with your marching orders. Who should do what, when, and how? So we can leave with a sense of what the mission is. That would be great. So Aarin, go ahead.
I just wanted to respond to my sis in the back from the Hill. My concern, and part of the reason why I'm here, right, is to make sure that when we're even thinking about research, like you mentioned, that we are at the table and doing that kind of work, but also that we're really careful about how it can turn into over-surveillance, and it can turn into legislation that looks into all the things that I was discussing, because that can also happen. If we know that pregnancy and pregnancy outcomes are being criminalized and black women are having dangerous outcomes, then that means black women are being put into the child welfare system and all that. So I just want us to be thoughtful as we're sitting in this room about what that turns into. And I also want to just mention, outside of all the beautiful things that obviously Jennie Joseph is doing, to even think about a project that's being done throughout the country called Best Baby Zones, where they go into communities that have high rates of infant mortality, like Oakland, like Cleveland, it could be DC. I know a lot of cities have applied. And what their goal is to not just change the infant mortality or the maternal mortality, but to change the community and to give resources to that community. So what that can look like is in Oakland, say we're gonna give you resources to open up a fresh farmer's market, right? And like, that is being creative, and I think that's one of my takeaways for everyone, is to be creative. Or in Cleveland, I believe it was, is one of the issues and the stressors on the community and on the women in the community and the mothers in the community and the fathers was like transportation. They wanted to build a train through the city. So what did? They provided them resources and skills to fight back against that. And that minimizes these stress issues, right? So like, let us all be creative. And I know another sis mentioned like human rights. Like, we just to think about, like, this is a human rights issue too. So like, not only are we talking about criminalization, not only are we talking about health, this is a human rights issue, and I know we're in DC, we should be advocating it, to think about it and out of our community of colors, but larger, because we are humans. And we are the cornerstone of it. I think black women were the creators, actually. So,
thank you, Aarin. So I'm going to work my way down. Jennie, why don't you share with us any responses and your marching orders?
I absolutely, again, want to stress, start with yourself. Start researching, start talking to others. Share what you know. Get with your sisters, get with your friends and ask them, what was your experience? How was your birth? How did you fare? Because we can learn from their story, and then we can learn to support each other, and then we've got a foundation. Because what we know is our women, the women that come through our clinic, they have a 25% C-section rate in an area where it's 35 to 40. These women are being delivered in a hospital system with no support, without doulas, without midwives, and yet they thrive. Share with each other, start there, and keep moving, looking for people who are interested in this work, helping them on a career path to get into this work. We'll just do it the other way, start from the bottom up.
Thank you. Thank you.
Yeah,
Joia.
thank you. So we did a Hill briefing. We had over 200 people to come. We did it along with the Caucus on Black Women and Girls. When I say we, I mean the Black Mamas Matter Alliance. We had the president of ACOG. We had also a researcher who works on racism, Dr. Felita Jackson. And so we are continuing to do work when it comes to on the Hill. The Urban League is going to do one, participating in this. And so I do think that there is a lot of movement. We have, my organization has recommendations that we go with that are listed for what we can do specifically around maternal mortality. And we work with the New York City Health Department. We work with Kalamazoo, Michigan, Mississippi Health Department. And so it's important that we do that. Also, thinking about the bills, there are a couple that we've been trying for a while. The one is just counting, right? So as you hear the 700 to 1,200, the reason there's such a wide range is because the deaths are not counted accurately. And so we're just trying to get the states to count the deaths accurately. There's some other bills that are more around rural access because there's a lot of rural closures of hospitals and just counting what's happening in rural closures. There's also a bill looking at perinatal quality commissions and what they could do. And then lastly, our marching orders are really to participate in the Black Maternal Health Week. And then to build up the power. We need this together. Ebony's a part of Black Moms Matter Alliance, and so how I know her is because of us doing this work collectively. So if we don't build power collectively, we're not going to be able to get this done.
Yes.
Carolyn.
So for the Catholic health care situation, there are 2 laws. Well, there's a number of federal laws, the Church Amendment and the Weldon Amendment, that basically says that any healthcare provider that receives federal funds, they can refuse to give abortion, sterilization services as long as they say they do it for their religious beliefs. And also anyone who receives federal funds can't discriminate against someone who refuses certain types of care, abortion, sterilization for religious beliefs. So we could try to push back against those laws. The Trump administration, the Health and Human Services Department, they're like crazy. Not crazy, I'm sorry, but a lot of them are evangelicals and like pushing forth laws that would give religious objectors more and more protection. So there's a new rule, HHS rule, that they just ask comments for that would allow healthcare providers to refuse all types of services. And then there's things you could do on a state level. So we're trying to push for proactive state laws that says that healthcare providers can't refuse these type of services. So there's things that people can do. And also we're trying to collect stories too, because a lot of people just don't know about the issue and educate people about the issue.
Thank you. Aarin?
And everything that everyone else has already said. And to remember that, I think of what Lynn Paltrow, my executive director, always says. We must work, I wrote it down, we must work to ensure that we have a culture of life, which is something we cannot do if we do not value all of the women, no matter their circumstance, who give that life. And I think that summarizes everything, but that includes the unpopular things as well, and that is really, really important.
Thank you. Laurie?
I remembered what I was going to say. It was very basic, which is we need to share our stories, right? We have to pass down those stories to our children, our nieces, our nephews. We have to share the good, the bad, the ugly, and like our hopes and dreams for them to have better experiences in the future. The other thing is, in the future, like my organization, the reason we do community-based sex ed is so we can include everyone, right? So that we can use an LGBT inclusive curriculum, that we can include people with disabilities, that we can include everyone, because our state's curriculum is never going to do that, right? It's never going to happen in schools. And the other thing is that we have bought a property in the West Jackson neighborhood. It's a blighted property. I think I had put a picture that I sent y'all, but anyway, it's we are building a all options pregnancy and parenting resource center. It's basically an anti-crisis pregnancy center, if y'all are familiar with what those are. Oh, look, we have, yes, there's our beautiful greenhouse. It actually has extra space in the back that we're planning on using for emergency housing. We haven't quite worked out how that's going to work yet, but that's our house. It's a 3-bedroom, 2-bath, and we're hoping to host childbirthing classes and parenting classes and everything, sex education classes, and it's across from a high school, and it's 6 blocks from Jackson State, and that was very intentional. And like, we just want it to be a positive space in the community, and we're trying to buy the 3 empty lots next door, so that we also possibly can do a community garden and some other, expand the emergency housing models possibly with like some tiny houses. Like, we're trying to think outside the box, right? We have a constant need for emergency housing for pregnant women. We have a constant need for emergency housing for LGBT youth who are kicked out of their homes. And so we're working collaboratively with some other organizations to try to maximize this property that we bought, and we're in the process of fundraising. That's www.msrepofreedomfund.org/donate. But yes, like, so that's our vision, to have our diaper closet, to have this place where if you need something and we have it, it's yours. Where there's a free library on the front porch. I'm so sick of seeing hipsters with little free libraries in their yards in places where everybody has books. What the hell is that, right? Why do you have a little free pantry in a place where everybody got food, right? Like, that's not revolutionary. Stop. So we're going to put it where folks actually need it. You know what I'm saying? So like I've alerted all the white allies to send me their books, send me your food, and I'm gonna put it where folks actually need the things, and send me books with black people in them.
Yeah.
Right? So like folks have been put on alert that that's what we need to do. And our ultimate goal is to train 30 black doulas and 2 home birth black midwives, possibly in the next 2 years. So we're working on trying to find some grant money to do that.
All right.
So support us all.
Well, it's a beautiful note to end on. So I hope that we have accomplished our goals to describe the problem, to have our moment of expressing how we feel about it, to have a greater understanding of the different elements of the problem, and to get our marching orders about what to do. So please join me in thanking our wonderful, wonderful panelists. And this also concludes our week of Her Dream Deferred.
Oh, wow.
Thank you all for spending time with us, for supporting our efforts here. We ask you to follow us. So follow us on Twitter, follow us and on all the other stuff that someone my age doesn't know anything about. Facebook, Instagram, whatever. Join our mailing list. If you like this kind of programming, let us know. Let us keep in touch with you so you know what happens with this conversation and all the others that we've been having this week. Thank you so much for joining us.